For the next session on anticoagulation. I'd like to present the next speaker, Dr. Sambet Sahu. Dr. Sahu is the medical director and chief consultant in critical care in King's Hospital, Hyderabad, and his main area of interest is liver transplantation and ECMO. So he's going to talk to us today about advanced anticoagulation monitoring and feasibility. Dr. Sahu, thank you.
Thank you. It's a very fine balance between bleeding and thrombosis. And it can be sometimes very tricky and can prolong the ECMO duration. But once you want to measure and monitor anticoagulation, it's the purpose is not only for ECMO, but it can also be used in when you're doing complex cases like liver transplants, when you're doing cases for interventional radiology, more and more for polytrauma, and in a lot of neurological in the neurological ICUs. So this talk would be just a primer for what we can do and how do we monitor anticoagulation or advanced anticoagulation. So it's easy for the other speakers, and it's mainly directed at the students and not at the teachers present here. So and once you have ECMO, by default, it is a thrombotic state by default, but it can be complicated because of the disease per se, because of the anticoagulants we use, and also because once you start introducing more and more complications into the ECMO circuit. Now imagine if you have an ECMO circuit, along with that you throw in a CRRT machine, along with that you throw in a plasma pheresis. So you're introducing more and more circuits, you're doing giving more and more products, and the conventional methods of diagnosing the coagulation parameters like your blood BT, your bleeding time, your clotting time, your D dimers, they just tell you a snapshot of the whole story. They are the in shots of the story. They don't give you the full picture. And also the time taken the, for you to come to a conclusion and rectify it or treat the patient is quite large, and you might miss the boat. So these monitorings help you give a complete holistic picture of what is happening in the body with the circuit, with the disease process, and also to help us treat the patient faster. So we already have thromboelastography, but can we do better is the question. So, one second. No, don't have a slide. Okay. Now, anticoagulation, if you look at the down at the bottom half, you would have the monitoring methods. What we ideally need to have is a real-time thing, but these are all fancy, these are all costly, these are only in what you can say research institutes. But people have tried when they wanted to study about the ECMO circuit per se. They have utilized optical devices, fluorescence devices. They have used frequency like the sound intensities, and they also so this is what people are trying to achieve. Just if you hear the frequency of the machine and you try and record it, that gives you an idea of if is there a clot developing in the inlet or the outlet. So this is what this shows. Some have even tried fluorescence labeled fibrinogen, and then you have a look at that. So, and some have used high spectral cameras that look at the uh, pump, and then they try and get a real time sense of what's happening to the clot. But this tells you only about the pump. What we need is about the disease, about the patient. We are not trying to deal with the machine, we are trying to deal with the patient here. So all these things, all the conventional methods, they do not reflect the role of cells or the contributions of the local vascular tissue conditions. And they miss the impact of platelets, they miss the impact of thrombin generation and the clot strength and the clot structure. So this is what we have been using now, either it is a thromboelastogram or a ROTEM. My experience all has been with the tech, but I know Dr. Poonam is a huge proponent of Rotem here, so I'll try to just call it as an analyzer, not a fronter. So it's a point of care machine which measures the hemostatic potential, and it, most importantly, it demonstrates the contributions and interactions of all the components. So the technology is pretty simple. TEG and ROTEM, they are just, you turn them upside down. So in TEG, you have a torsion wire and the pin rotates. In ROTEM, it's just the opposite. The cup is stationary and the tension wire rotates. You have advantages and disadvantages of both. Both are bedside. So TEG is very sensitive against agitation. So it cannot be used in wartime scenarios where you have a lot of movements. uh, then you have the turnaround time is 30 minutes. Here they call it 5 minutes, but I'll come why tech also can be better. You have two measuring channels, and here they have four measuring channels. This is more subjective. You need to do some uh, hard work to get it done through a manual pipette. This can be PC driven, and you have platelet aggregometry from both the things. You need a quality control check every 8 hours, and here once a week. So this is the basic difference between the monitoring methods that we have. But all of them use modifying agents or activators, as we call it. The activator can be kaolin or a tissue factor. If you want to neutralize the heparin in the body, then you need to have an heparinase. If you want to do a platelet aggregometry, you need platelet activators. But the concept here of the TEG is that you have, as the cup rotates, the pin remains stationary. The initial is the reaction time, and this is what it tells you. And this is the kinetics time, and that's represented by K or an alpha. And you have a platelet strength, which is a combination of your platelet function, platelet number, and the fibrin. So it tells you the amplitude, and that's the platelet thing. And then you have a coagulation index. So it's a linear combination of all of that, and that basically tells you whether the patient is hypocoagulable or hypercoagulable. And then you have a lysis time, so which tells when there's a clot lysis, there is fibrinolysis happening, or there is some antifibrinolytic thing. So this is the cosmic balance of what we understand as creator, preserver, and destroyer. So that is how you understand the whole coagulation cascade. In summary of the graphs, so here you have an R time, you have a K time, you have a lysis time, and you have an MA, and this is all that you get once you do either a TEG or a ROTEM. Thus, the nomenclatures might differ. Uh, and then you get the clot kinetics, etc. So this is how a normal TEG tracing looks. And here you have the R time, here you have the clot kinetics, you have the maximum amplitude, and you have the lysis time, and you have the coagulation time. This is how an hemorrhagic TEG was looking. The patient is bleeding, so you, of course, the clot reaction time is high, so your R time would be prolonged, your K would be decreased, your maximal amplitude would decrease, and your lysis would decrease. This is a thrombotic TEG where the R is quite normal in range. You have an angle, you have an MA, maximum amplitude which is very very high, and you have a lysis which is again within the normal range. This is how a fibrinolytic TEG would look, and the R time, the angle here, you have an MA, but here important is your lysis time and the coagulation index. And this is the decision tree that you take of what to give and how much to give and when to give. So you on the hand and this. So with this background, can you all tell me what is this? This patient is bleeding, and this is the TEG. Can any one of you tell what could be the probable cause? It's a normal TEG, the patient bleeding. Okay. So just to tell, so TEG does not give you the whole, even TEG does not give you the whole story, but the common sense here, if the patient is bleeding, the TEG is normal, maybe it's a vessel injury. It does not tell you about the von Willebrand factor deficiencies. It does not tell you about presence of platelet inhibitors. So a normal TEG with a bleeding patient, you need to figure out these two things. And the treatment would be suture the patient. For von Willebrand, you need to give desmopressin. For platelet inhibitors, you need to run a platelet mapping. If you have a problem with enzymatic pathways, the reasons could be multifactorial, could be liver disease, could be congenital disease, patient on ECMO, could be factor deficiencies, could be residual heparin. So if you have this kind of patient and the patient is bleeding, it's difficult to tell whether it is because of a factor deficiency or because of residual heparin. So the probable causes here would be factor deficiencies, platelet deficiency, or dysfunction, or even with a residual heparin. And to diagnose a residual heparin, you need to add an heparinase and then normalize it and see whether it is still prolonged or there's some other cause to it. Now, if you have a fibrinogen deficiency and the patient is bleeding, you need to give cryoprecipitates and FFPs. The tech cannot distinguish between low platelet count and low platelet function. And that is very important to understand. That is where we might have to either do serial text to uh, uh, get an understanding of it, or you have to run a platelet mapping. Now, in this, where you have a low MA, this could be a platelet, and you have run it with a kaolin with heparinase. So you have negated the effect of heparin. This is the TEG, and the MA is low. So most likely it's a platelet dysfunction or a low platelet count. Now, how do you distinguish again between that? So, and the patient is bleeding, of course, you need to transfuse in both the scenarios. But here, if you have this kind of a low angle, a low MA, and then you have a, sorry, and then let me go back. So here you have a low MA and the patient is bleeding, and this is more kind of an hemorrhagic TEG with most likely an enzymatic pathway defect, or that is a fibrinogen pathway defect, or an platelet function or platelet number defect. So this is what it would look like where you have an enzymatic pathway defect. The R would be much more prolonged than the other side. Now, if you have to treat them, you need to give them a lot of FFPs. If you think it is platelet count, transfuse them, platelet function, you have to transfuse, but I'll come to that, how you differentiate between platelet count and platelet function in the next few slides. Now, this is another important thing as more and more people, the patients are coming up on VA ECMO, where they have undergone a PCI, where they have given the patient apixaban or all those things, and then the patient has fibrinolysis, whether it is primary, secondary. So all that we need to be very careful when we are doing a tag on these patients who are on these drugs. So, but if you want to recognize hyperfibrinolysis, and that is when you need to first find out whether it is primary or secondary. Secondary, as we all know in medical ICUs, is because of DIC kind of picture, and fibrinolysis primary is because of the drugs that we give in to remove a clot. So that is, so this CI should give you the difference between what kind of fibrinolysis the patient is happening. Is having. Now you have platelet hypercoagulability. This is because of sepsis, DIC, malignancies, and sometimes antithrombin deficiency. Now this we are also seeing more often, and of course hyperhomocystinemia is cystinemia, which is a major cause of stroke in young patients. So, if you have platelet hypercoagulability, this is how it could be because of a rapid clot formation. You can see here this high alpha is cause of a rapid clot formation. You might have to give a platelet inhibitor. And if you have this kind of picture where you have a very low R, then you might have to give anticoagulation. So this is where you have an enzymatic hypercoagulability. This is not platelet hypercoagulability. Uh, Now, the next, how do we differentiate between if something is because of platelet inhibitors or platelet functions, and when specifically when more and more often we get patients, elderly patients, when we put on ECMO who are already on antiplatelet drugs sometimes, And these would be the antiplatelet drugs that we can measure the activity of these antiplatelet drugs by platelet mapping. You have these ADP receptor inhibitors. Clopidogrel is pretty common, but nowadays patients who are going for PCI, we give them a loading dose of prasugrel. Then we have thromboxane, the time-tested drug aspirin, and GP2B3A inhibitors like abscesimab and tirofiban. Now, for this, the concept here is, let us assume that there are three patients with this is the primary profile of these patients, and if we give a drug which gives them 50% of inhibition, you can see that these patients from hypercoagulable, he's still in the hypercoagulable. But if his primary state was this, he becomes normalized, and this is what we want to achieve. But if he was in a normal and you go for a hypocoagulable, the chance of bleeding increases. So this is the concept of doing a platelet mapping, and this is how a platelet mapping is done. So this is you get with kaolin heparinase, and if the patient is highly heparinized, you get this uh, activated fibrinogen thing. If the patient is on ADP, that is ADP receptor inhibitors, like clopidogrel, you need to look at that, and this tells you about the inhibition of aspirin. And they basically provide an exact percentage of inhibition of ADP inhibitors and aspirin. So coming, are we doing, can we better this? Though we have come down from 90 minutes to 60 minutes, and here a complete tech requires 30 minutes. The better way is the newer products which are not subjective, which are cartridge based, which give you instant results in 10 minutes and combines everything. It tells you about the kaolin activity, it tells you about the functional fibrinogen activity, it tells you about the heparinase activity, and and you get a diagnosis in 10 minutes, and so you can work on it. And then you just have to run uh, the platelet mapping to get a better picture of that. So this is a small primer into how do you go for, so the other speakers to pick on this. Thank you.
Thank you very much, Dr. Song, for an extensive review of thrombosography. I think we're going to move on to the next speaker and we'll take the questions at the end.
Good afternoon, everybody. Our next speaker is Dr. Poonam Malhotra. She is Professor of Cardiac Anesthesia and Urology.
No, it's okay. I'm fine. Just a slip of my step. I'm sorry. Can I have that?
Heparin alternatives practicality. It is my humble respect to the speakers to please stick to time strictly.
Am I next or Lakshmi next? Yeah. Thank you. So I'll be very fast because the organizers have asked me to complete it in 10 minutes. Humanly impossible, but I'll just skip through a list of um, heparin alternatives. What Sambit spoke on was my talk, which I always speak on because it's our research. But thanks to Vivek and thanks to the organizers, Dr. Wander and team here, coming to Ludhiana is always very warm and welcoming, not because I'm a Punjabi, but because I feel this is home to one of the best human beings in India. And the culture here is radiant. Heparin alternatives and practicality, very difficult to speak, but we know the downs of heparin. We've been speaking, Malis talked about it in the morning, that right from thrombocytopenia to osteoporosis to atrial fibrillation, we use heparin in such wide uh, varieties of uses, but most of it is also bringing about antithrombotic, anticoagulant, as well as osteoporotic effect. Unfractionated heparin brings about resistance, allergy, thrombocytopenia, and in 1 to 2.7% of patients, when we give heparin and we are trying to see the heparin effect on an ACT or an APTT, we see that there is generally, by the starting of heparin, a decrease in antithrombin 3. Now, pathogenesis of HIT brings about the formation of a PF4 antibody, and there is, when we go on ECMO and initiate ECMO, because of the DIC, because of the the hemodilution, because of the SIRS, because of the cytocomplement and the cytokine pathway, there is a thrombin burst and a thrombin storm. So, what is the effect of using alternatives to heparin? It is to decrease or negate the effect of this thrombin. That is, to do a test which is going to decrease the thrombin inhibition or is going to bring about the thrombin inhibition. So HIT is heparin-induced thrombocytopenia, where the PF4 antibodies form with the heparin, and when this patient comes for the second time, the heparin reaction is very, very fast. It's immunogenic, and there is no effect of the anticoagulant effect of the heparin. The result is either a heparin resistance or a heparin induced thrombocytopenia, which could be type 1 or type 2. But it's a difficult challenge because these patients need anticoagulation, whether for cardiovascular or ECMO affairs. Now, heparin and heparin sulfate kind of molecules have been mimetic and they've been brought about. And this PCOS trial brought about a lot of new heparin alternatives into the market. Alternatives to heparin should ideally have rapid anticoagulation. With less experience, the antibodies to HIT should be transient or absent. The acute or recent onset of HIT, if it is there, then only an antiplatelet drug or an alternative to anticoagulants is needed. So if I have a marker here, I would just like to point out to these two things. My previous slide, we have alternatives to this factor 10A, which is the common pathway from the extrinsic and the intrinsic pathway. We have the factor 10 pathway, which is low molecular weight heparin, danaperoid, fondaparinux, and idraparinux. These are the neuroheparin alternatives. The other is the fibrinolytic pathway here, where you have a direct fibrinogen blocker, the Ancrod, which is very nicely antithrombotic. It's its name, Malayan snake viper venom, and it has been used in a few scattered case reports with good results, where fibrinogen is blocked when it is forming into fibrin, the first clotting factor. When we have direct thrombin inhibitors like hirurin recombinant, the lepridine, the bivalirudine, the agatroban, and zimalagatran, which is a new oral direct thrombin inhibitor, we have a gamut of these drugs with different chemical structures to know that some of them are directly from the animal serums, but most of them are synthetic. So most of the direct thrombin inhibitors, which we're going to talk about, whether it is Ancrod, which is a direct one, which with the thrombin-like enzyme, which brings about proteolysis of fibrinogen, and it does not form any cross linkages with heparin antibodies. So most of these heparin alternatives have three advantages. Number one, they do not bring about any cross reactivity with heparin antibodies, which heparin does. It acts and binds with antithrombin 3. Its activity as a proteolytic and anticoagulant becomes 1,000 fold more. The result is the formation of a HIT or a heparin resistance and enhanced bleeding and enhanced antithrombosis. At the same time, danaperoid, which is a synthetic analog and a mixture of heparin, dermatan, and chondroitin sulfate, is a factor 10A inhibitor with only 10% cross reactivity. This is the only one of the heparin alternatives with some cross reactivity, which is just to the tune of 10%. It is derived from the porcine mucosa extract. The other one, which is a direct inhibitor, which is directly from the animal, is the lead salivary gland extract, that is the hirudin. But agatroban is a synthetic peptide like a arginine molecule. It's an analog of 66 amino acids, and it is a direct thrombin inhibitor with no cross reactivity. Leprodine, on the other hand, is cloning and expression in yeast cells, and it is a recombinant hirudin. It has no cross reactivity. Bivalirudine, used most in ECMO in recent times, is a synthetic peptide with hirudin derived from the leech, but it's synthetic, and its direct inhibits the thrombin. And another direct thrombin inhibitor is Adixtra, and that's a 10A inhibitor, not the 2A inhibitor, but a factor 10A inhibitor, which is the fondaparinux. So low molecular weight heparin and fondaparinux are the new ones which bring about a lot of changes. Now, as I said, factor 2A is a 10A inhibitor, is low molecular weight heparin. We use a lot of it in COVID. The coagulation test, which is necessary to monitor, is ACT and APTT enough? No. What else do we need? We need factor 10A. And this factor 10A with APTT and ACT gives about very good low molecular weight titration to be done in our COVID patients on HIP. We did not require heparin when we were giving a 2
days, 2 times a day or 3 times a day in enoxaparin or deltaparin of low molecular weight heparin. So whenever we feel that there is a need for an extracorporeal circuit, if my hip test is positive and I'm going in for urgent surgery, then there is a need for alternative anticoagulation like a heparin alternative, like low molecular weight heparin or bivalirudine. But however, if there is a elective surgery, it's best to follow, wait, give it 2 to 3 times, repeat the test, and after 2 to 6 weeks, undergo with a low dose heparin again. Ancrod cannot be used in emergencies. It's highly antithrombotic. Ilioprost or epoprostenol, which I've been seeing most of the cardiologists use in the cath lab, is a very, very good alternative to heparin. It can be used. These drugs bring about a lot of unacceptable hypotension, and that is the reason why we may not want to give them. Danaparoid sodium, however, is the most widely used alternative to hit in DVT, in dialysis, as well as in CPB patients. So, HIT and DIC patients may already be hypofibrinogenemic, and therefore these patients may not want Antrod, and therefore we don't use Antrod so much on ECMO. But enoxaparin or deltaparin, kind of a low molecular weight heparin, has had large controlled trials with anecdotal reports of persistent or recurrent thrombocytopenia during treatment. And one of these latest trials from Cecily Alexandros brought about significant relevant titrations of low molecular weight heparin. Enoxaparin for unstable angina following in high risk PCI, when the patient was put on ECMO, was a very, very good choice over the bovine lung heparin. And enoxaparin subcutaneous dose showed no cross sensitivity to any heparin antibody. And it was used in a very low dose, maintaining low fibrinogen levels. Safety and efficacy of enoxaparin versus unfractionated heparin has also been shown on ECMO as early as 2004. We used it very rampantly in COVID 19. And in COVID 19, we saw a lot of survival with heparin free periods managed only on low molecular weight heparin alone. If we come to the next 10A monitor inhibitor, which is danaparoid sodium, a very good drug with good anticoagulation effect depending on adequate 2A by antithrombin levels, but it is not available in case of overdose. Therefore, it is important to stop the drug when a lot of bleeding happens. A lot of trials have said that there are periods of no bleeding and periods of spurts of bleeding. So, whenever the period of bleeding comes along, it is good to stop the drug because this drug has a very long half life of 25 hours, and this is the drug probably with the longest half-life. Modified treatment for with danaparoid sodium says that it requires also long operative times for closure, and therefore with 23% of them undergoing post-operative bleeding, it's not right. I would like to bring your attention to this. When we talk of there being a thrombin storm and bringing about bleeding, then thrombin has two sites where it acts. Thrombin or factor 2, as it is called, when it is inhibited by most of these 2A factors and the direct thrombin inhibitors like hirudin, bivalirudin, and argatroban, have a active site which is site 1 or the free site, and they have a bound site or the fibrinogen site which is site 2. Now, most of the drugs like bivalirudin and hirudin, they bind to both the sites, and that's why they are very good for heparin alternatives. However, agatroban being a group 2B3A inhibitor and a direct thrombin inhibitor binds only to the active or the free site of thrombin and not to the fibrinogen site. Therefore, it, with a very short half-life, is a very short acting and a short duration, less potent than bivalirudin heparin alternative during ECMO, used more in the cath lab for short procedures. Now, when I go on to the hirudin and lepidolin analogs, the undesirable side effects are generally hypersensitivity reaction with skin rashes. Protocols for hirudin anticoagulation during CPB exist, and these protocols call for very low dosages of these drugs. But remember, most of these drugs do not need just ACT or APTT alone. They need a good monitoring and a good sensitivity level by doing a ECT. Icarin time is available only in one machine that I have known of and have done. And because we do use bivalirudine a lot in our cyanotic babies who are undergoing complex congenital cardiac surgeries at AIMS, and that is the Ecatem, which is the reagent that we use instead of Aptem when we are using the Extem, Intem, and the Heptem on Rotum. So Ecatem is the only reagent available which measures the ECT. There are very difficult and big assays of ECT which can be done with a huge turnaround time of more than 2 days for ECT assay in the histopathology laboratories. But as early as 1996, they said that hirudin is best monitored and so is bivalirudine with an ECD monitor. But short of that, what do we do on ECMO? An APTT, ACT with good anti-10A levels. Anti-10A levels more sensitive for low molecular weight heparin, but also sensitive in today's day and age for bivalirudine if done. But to my knowledge, a ACT, APTT with a rotum and an increase in the CT angle of a heptum and an intem on rotum is what suffices. So if I use bivalirudine with favorable outcomes for off-pump surgeries or for aortic valve replacements, which many people in literature have done and we have also done, we've been using bivalirudine since 2018 at locality. This was a patient coming with HIT because the first surgery done in 2018 was a pulmonary thromboendarterectomy. This 30-year-old lady came with thromboendarterectomy done in 2020. In 2023, this year, she came up again with a repeat or a redo thromboendarterectomy, and we used a bivalirudine because her HIT antibodies were positive. With a positive PF4 in her body, we decided to use a very low dose bivalirudine infusion, which we are adept at because we use the same for babies in our congenital surgeries. We use zero point 0.5 milligram per kg body weight per hour, and we successfully came off on an ECMO. At AIMS, we use a lot of integrated ECMO, all complex congenital surgeries, adult redos or re-redos that come to us as a tertiary care center. We come off on a VA ECMO. We have 3 cardiohelps, and we use one of the cardiohelps to come off on low flows ECMO. Now, when we were using a cardiohelp, on the second day there was a redo because she tamponaded. And once the redo was done on bivalirudine, and we saw a clot sitting right under her skin over the sternum, we decided to restart the ECMO, which we had temporarily stopped during the surgery of tamponade synthesis. Once we restarted the low flow bivalirudine in the night, what do we see? What you can see here, a clot in the oxygenator. So the moment you are going back on a low dose bivalirudine, where there's no heparin being given, you see clotting. And this clot, small ones were also there in the return cannula, which was a disaster. Fortunately, as Nick was saying in his talk, Dr. Nicholas very nicely mentioned, and so did Dr. Sachin, we have a reverse flow of a VA ECMO where we use a bridge. So we took the patient on the bridge and we started a very low dose heparin. And we started a low dose heparin, restarted the bivalirudine with the heparin, took a chance, and with low flows ECMOs, this is what we did. This is in press today. We maintained the hematocrit of the patient, gave 2 to 3 units of blood, maintain the PCO2 around 35 to 45 and with a PO2 between 70 to 90 and an RPM very low of less than 2000 RPMs, we were able to come off bypass. And what helped me with this patient was doing a rotum there and then at the bedside. And what did I see on the rotum? Though my ACT and APTT were within normal limits, I saw a prolongation of the CT on intem and eptem, which made us all as a team be reassured that the dose of heparin and bivalirudine together could be used to tide over this crisis when we are doing a circuit change with an oxygenator change on ECMO. This is a disaster in many. Had we not had the bridge, had we not judiciously added heparin with the bivalirudine and taken a chance, we would not have saved this patient. She went home on the 19th day from the ICU and 36th day. So bivalirudine did not increase any post-operative bleeding and transfusion requirements, and this is where bivalirudine scores over heparin. A, no cross-reactivity. B, a shorter half-life of 25 minutes vis-a-vis heparin, which is dose-dependent half-life of 30 to 150 minutes. And Thirdly, it requires no cofactor to bind with. There's no antithrombin. The only downside, less bleeding, absolutely no cross-reactivity with any antibody. And the only downside to bivamelagon is it does not have a reversal. There's no protamine. So till we get a reversal, bivamelagon is a very good and a safe alternative. Arginine, which mimics the argatroban, which mimics arginine, binds with the thrombin. It's a reversible binding with a very short half-life. It is used as Segressor has reported with 80% blockage in the cath lab where hit antibodies are suspected. But I would say at the end, when we use alternatives to heparin, then in pregnancy, as Huda pointed out in the morning with peripartum cardiopathy, cardiomyopathy, danaporoid sodium and ECMO is good. Those undergoing dialysis in the cath lab or a high-risk PCI in the cath lab, a tirofiban or a argatroban kind of group 2B3A is good. Undergoing hemofiltration, again, danaporoid is good. Intensive care units, any direct thrombin inhibitor is good. You could use bivamelagon. For percutaneous interventions, argatroban is the first choice and bivamelagon for any coronary angioplasty. I would like to end here since I'm short of time that antiplatelet therapies with NOACs are on the horizon. You have zimalogratran, which is an oral anti-direct thrombin inhibitor. You have tirofiban and epoprostinol, which are group 2B3A inhibitors. What is new are the ways we are going to use it. When to start, how to start, what to give, when is going to be our this thing. Recent publications by Zika et al. Have pointed out that when you are giving low molecular weight heparin, then to prevent the troughs and the valleys, do your anti-DNA, anti-10A levels 3 times, not once, as has been given by ELSA registry. Fondaparinux, with a long half-life of 17 hours to 25 hours, is on the horizon, as are protein C activators, which have all of antithrombotic, anti-inflammatory, and profibrinolytic effects, which heparin did not have. Heparin has no anti-inflammatory effect. And some of these recombinant tissue factor pathway inhibitors, DX9065, synthetic low molecular weight inhibitors, which have reversible factor 10A inhibition, are on the horizon. A good alternative could be a molecule like tirofiban, which has some thrombocytopenic and some bleeding effect. But I would like to conclude that the risk of using non-heparin agents must be considered on a case-by-case basis. Till we have more randomized controlled trials, synthetic heparin analogs will be a very good alternative to heparin in cardiac surgery. The changing landscape of anticoagulation in pediatric ECMO with the use of direct thrombin inhibitors, where bivamelagon rules the roost, is there, but its lack of a reversal agent discontinues its thing. This was 2018 SWAC also at New Delhi, which we enjoyed with Dr. Robert Bartlett. And as the president of SWAC also this year, it's my proud privilege to welcome all the ELSO people, Christine, Peter, as well as Matthew Payden, with whom I've had the privilege of traveling from Delhi, and it's with ELSO that SWAC ELSO stands. And I'm sure I see the future of SWAC ELSO in so many students who've gathered to hear, learn more from everyone. Thank you all.
Thank you, Dr. Khanna, for an extensive and crisp talk. We go over to our next speaker.
The next topic for today is periprocedural anticoagulation strategy and role of antifibrinolytic agent. We have a very eminent speaker with us, Dr. Lakshmi Raman. She is Medical Director, ECMO Program at University of Texas. I welcome you, ma'am. Please start your presentation.
Thank you to the organizing committee for inviting me to talk on this. I'm going to talk from the perspective of somebody who takes care of pediatric and neonatal patients, and peri-procedural anticoagulation, the role of antifibrinolytic agents, is something that we think about constantly because one, in neonates and pediatrics, we don't have the luxury of having very big cannulas, and so to run heparin-free circuits is not something that we do a lot. I think I'm having some issues. And 12 to 15 minutes, I'm hoping to talk about first whether we need to have a discussion about the procedure that's going to be done. I'm going to do some literature review, mostly about pediatric and neonatal patients. and then the use of antifibrinolytic agents, and some of the work that has been done by the Peace Consensus Conference, and share some of the recommendations from that. So, how do we define procedural bleeding? We say it is anything within 24 hours of the procedure. And then you have to really define low risk bleeding versus high risk bleeding. Maybe I'll just talk and we'll just ignore the slides, I guess. Um, and I think how we define major procedures or minor procedures is based on some surgical literature. Some of the major procedures that we think about are laparotomy, and in neonatal population, CDH repair is something that we often do. Lung biopsies, thoracotomies, cardiac catheterization, and then in tracheostomy is something that's being done more and more frequently. And some of the minor procedures is anything that is done percutaneously. So the first, I'm going to walk you through a case that we had a few years ago. Um, it was a 2-year-old child who had influenza, also strep pneumonia, and had ARDS. So we cannulated him onto VV ECMO. And then somebody decided on day 2 to day 3, it was a good idea to try recruiting his lungs. So they put him on IPPV, which is a respiratory treatment that we do, and give him some high pressures to the lungs. So then what do we have in the middle of the night? They realize we get routine chest x-rays. They do a chest x-ray and he has, you just have to imagine as I'm talking, sorry, there are no slides, that he has bilateral pneumothoraces. So what should probably somebody do if you have bilateral pneumothoraces when you're on BB ECMO? Any students in the audience who want to take a guess at the answer? I think the rule of thumb to say is, are you having any interference with your flow? Are you able to support the patient adequately on ECMO? I think those are some questions you want to ask. And if the answer is yes to those, then do nothing. Just turn down your ventilator settings and let the pneumothorax heal. But instead, that's not what our team chose to do. So in the middle of the night, they just stopped heparin for only about 30 minutes, and they decide to do chest tubes bilaterally. Um, and so this is the X-ray when he goes on ECMO, and he has bilateral pneumothoraces. They put chest tubes, and then his lungs remained whited out for a long time. And Dr. Barrett told us how diagnostics can be very helpful. So since his lungs remained whited out for a long time, we decide that we are going to first do an ultrasound. We find that both his chest cavities are filled with fluid. Then we hike him down for a CT, and we find he has large hemothorax bilaterally. So he then goes for, so this is the pneumothorax. This is going to work. Shall I just, okay, working now. Good. No. Okay. So we end up doing thoracotomies. And at that time, when we hike him down for a chest CT, we said since he's in the scanner, we are also going to scan his head. And he actually ended up having a reasonable size subdural hemorrhage as well. So we said it's probably a good idea to keep him heparinless. So we run him heparinless for almost a week and keep his flows generous so that his circuit remains alive. And finally, after we recruit his lungs using a jet ventilator, and then after 42 days of ECMO, he comes off ECMO and is discharged home. And his mom actually recently just shared a picture of how he graduated kindergarten with his graduation picture, and she said she almost thought she was not going to have that moment. So I think the one of the key things about talking about this case is to ask the question, if you are doing a procedure on ECMO, is the procedure needed? And if so, how am I going to do it? And so, okay, so that's the hemothorax, and that is his this. So this is a so there was a recent paper that was not that recent, about 10 years ago, and two centers joined together to look at their experience on fluid collections in the chest cavity and how what was their experience. So they had, between Loma Linda and National Children's Hospital, they had about 189 patients, of which 47 of them required placement of chest tubes, and then they looked at, for various reasons, for pneumothorax, effusion, hemothorax, and looked at the outcome of patients with and without chest tubes, and found that the mortality was significantly higher in patients who had a chest tube placement, though it was, yeah. You want me to airdrop the presentation?
Like everyone gets their products. So we got the oral Zimalagatrin last year. We used it in 3, 4 cases. We use Ancrod only in 2 cases, and that too in the cath lab for PCI with our Gatroban, which they were using at that time routinely. And we saw that over and above our Gatroban, Ancrod has a very good, we didn't report it unfortunately, but it has a very good anti-thrombotic effect. And that anti-thrombotic effect is where it scores. So you give Ancrod. Ancrod is it's a liquid kind which is injected slowly over a period of time. And we were three of us with hesitancy. And when we introduce something new, we don't give away the old. Like when we were stuck with this Vivalridine, we restarted heparin low dose because she was on 5 days without heparin, doing well on Vivalridine. But when you see a clot like that, and that too in the oxygenator, give what is the gold standard. Give a low dose heparin. So there also we used agatroban with Ancrod, but we did not know what the effect was due to. So that's why no reporting. But I myself have seen Ancrod in hematology cases. I work a lot with the hematologists for my research, and a lot of hematology people use it as an anti-thrombotic agent for thrombosis. A couple of them used it in COVID thrombosis with the high D dimers and with low molecular weight heparin, but I have not seen it being reported in literature. No. Nanoproids, there are many case reports, low molecular weight heparin, danaproid sodium, even fondaparinux now, where they are seeing the peaking with 10A levels. And I think most laboratories have come up now. This is, I think, something good that's happened post COVID. A, ECMO is more centers are being added. B, we're doing more laboratory tests which were yet, at least in India, not available. We were just doing serum fibrinogens, APDTs, ACTs, and simply D-dimers. But today we're doing anti-10A, we're doing anti-thrombin 3. Anything less than zero point 0.4, more than zero point 0.7, you are fearful of either a bleeding or a thrombosis. So those are good tests.
We'll go back to where I left. So we talked about the 2-year-old who had, these were his pneumothoraces in the middle of the night. They put chest tubes, and this is what his lungs looked like. And when we did the CT, this was his CT with a large hemothorax. So we had him on for 42 days on ECMO, and he came off. So that's picture that we celebrate the lives of our children. So they come back every year, and this is one of the pictures. Um, so I was talking about two-center experience about the use of chest tubes from Loma Linda and Children's National Medical Center. They had a total of 189 patients, 47 of whom required chest tubes. And then they compared the complications of patients, mortality for patients with and without chest tubes. Though it was not statistically significant, I think the study was not powered to demonstrate statistical significance, but you can see how the mortality was different between the two groups. And this was one of their patients. This was a 2-year-old girl with ALL and sepsis who was diagnosed with a right tension pneumothorax, and which was not able to be drained by a previously placed chest tube. So even though the circuit was not compromised and the oxygen saturation was between 93 and 98%, they still decided to go ahead and place a chest tube, which then caused pulmonary laceration and looked like the patient needed two thoracotomies and then subsequently had to be withdrawn from ECMO support. This was another experience on the procedure of lung biopsy on ECMO from Netherlands, and here they had 19 neonates and 6 children, of which 13 patients with lung biopsy had a classifying diagnosis, 6 patients had pathological diagnosis, and the use of lung biopsy led to diagnosis that then led to either withdrawal or help in recovery of these patients. And hemorrhagic complications in their patients were very small. And how did they approach the lung biopsy? They had an anticoagulation strategy. So what did they do? They lowered the heparin dose. They bolused with TXA 1 hour prior to the procedure, and then they put them on a continuous infusion of TXA for about 24 hours. They also had other blood transfusion parameters where they said we are going to keep the platelets greater than 100, fibrinogen greater than 1 gram per liter or 100 milligrams per deciliter. And similarly, another experience on repair of congenital diaphragmatic hernia. As I said, we do a lot of neonatal ECMOs in our center, and congenital diaphragmatic hernia patients do end up on ECMO. And when you have to repair them when they are on ECMO, you do have to think about what your anticoagulation strategy needs to be. So this was another experience again from Netherlands where they had earlier patients between 91 and 92 where they didn't have a protocol of using TXA, and then they changed the protocol from 93 to 95. That was group 2 where they started using TXA and they looked at the experience of what happened. And as you can see, there was no difference in the birth weight, age, or time of CDH repair. However, the duration of ECMO was shorter in patients in the group 2 where they did have a TXA protocol. And when they looked at blood loss in mils, total blood loss in mils and requirement of blood transfusion, as you can see, in group 2, both the blood loss and the blood transfusion requirements were blood loss was minimal and blood transfusion requirement was lower. And we, in 2017, we revised our CDH protocol in Dallas and we started doing early repair, which means once they go on ECMO, we do our congenital diaphragmatic hernia repair within 2 to 3 days. So we had 12 patients in the period of 2017 to 2020, where our protocol was on call from the OR, we repaired them at the bedside. When the OR called and said they are coming, we would give them 100 milligram per kilogram of aminocaproic acid, and then we would place them on an infusion. And then we would decrease the heparin infusion on the first incision. And then we said we were going to titrate the heparin to goal only in the next 12 to 24 hours. But then when we looked at our experience in 2020, what we realized was we had more thrombosis than bleeding. So invariably on the night of the procedure, I would hear that they would clot off the 8 French cannula and somebody had to pull out the clots from the cannula. And there was a significant clot burden in the circuit. So then we changed our protocol to where we did load them with the same amount of aminocaproic acid and kept the same infusion, but however, we decreased the heparin only to about 10 minutes, and then we ramped up the heparin to go anticoagulation within the next 4 to 6 hours, unless they had significant bleeding. And with that change in our protocol, we found that we had much less clotting of the cannula and the circuit. So the moral of the story here to show is that I think it is important to look at your own center experience around procedures and to have some guideline on how you want to titrate your anticoagulation. This is just a slide that shows the effect of how aminocaproic acid and TXA work. They cause lysine inhibition of the plasminogen and plasmin sites, thereby inhibiting the breakdown of fibrinogen into fibrin split products. And that's how these drugs work. This was another study published from Boston Children's where they looked at the impact of Amicar in a 10-year period from 1991 to 2001. And actually, currently, we are working with Dr. Payton Center and Boston Children's Hospital and Dallas Children's, the three centers. We are working together to look at the same experience now in the last 10 years with all the advancements in anticoagulation testing and things like that. So this they looked at the percentage of patients. So based on their previous experience, they decided who were the patients who were at increased risk of bleeding. So these were the patients that they decided was at increased risk of bleeding, which is in the next table. These were the groups of patients that had increased risk of bleeding, and then they started them all on Amicar. And then they found out how Amicar had helped, and the biggest impact was in the cardiac patients, where they found that their surgical site bleeding and post cardiotomy bleeding had been significantly reduced when they used Amicar. But when they looked at whether transfusion or bleeding was any different between the Amicar and the no Amicar group, they did not find any difference. And in the Amicar group, they had more circuit changes and increased clot burden in the circuit. Recently, there's a lot of publications about surgical outcomes and complications of bedside tracheostomy, and bleeding is a challenge. But I think having an anticoagulation protocol and how you want to deal with it certainly is helpful. So this brings us to the Peace Anticoagulation Expert Panel. So about almost now 3-4 years ago, Peter Alexandria and Jen Muzinski, with the help of NIH funding, got together more than 50 experts across the globe and looked at can we come up with some systematic review and PICO questions to answer various aspects of anticoagulation. And Ariana Williams and I, along with 719 other experts, were tasked with looking at management of ECMO anticoagulation in the perioperative period. So who were the population? Of course, it was the neonates and pediatric patients. And the intervention here was whether having a protocol and guideline, and then the comparison population was to no guideline, and whether it impacted outcomes. So what were the places where we looked at whether guideline helped, whether having a procedural protocol or guideline, any guideline about stopping anticoagulation, the use of antifibrinolytic agents, and then the use of topical hemostatic agents, and whether to have blood product transfusion goals prior to the procedure was helpful. So of course, we had only about 17 studies to look at, and with these procedures, what did we find? The outcomes we defined was um, mortality, bleeding and thrombotic complications, neurological outcomes, their functional status scale, duration of ECMO, duration of organ dysfunction, and the cost and transfusion reactions. But however, because there is not much literature and not many randomized studies, we could only come up with best practice statements and clinical recommendations. So what did the committee come up with? We said we have to weigh the risk benefit of any procedure, but certainly we also do not want to delay procedures that can help in diagnosis. As we saw in the paper on lung biopsies, they were able to make an impact. So that is so important to weigh the risk benefit of anything that you're doing at the bedside. And then identifying and optimizing underlying coagulation risk, and then evaluating the blood loss after the procedure for at least 24 hours. And then we divided the recommendations into post-cardiotomy and regular patients with bleeding risk. And in post-cardiotomy patients, we said having what were the clinical recommendations, having institutional protocol for systemic anticoagulation blood product transfusion was important. And it is reasonable in post-cardiotomy patients after cardiopulmonary bypass to reverse heparin and to delay the systemic anticoagulation. And again, for post-cardiotomy patients, the recommendation was against routine use of antifibrinolytic agents and to consider factors like factor 7A only in life-threatening situations. And good idea to keep your platelet goal greater than 100 and a fibrinogen goal greater than 150 milligrams per deciliter as well. And when it came to high risk bleeding procedures, having an institutional protocol for stopping systemic anticoagulation and having blood product transfusion goals is important. And it is reasonable to think about stopping or decreasing systemic anticoagulation and to consider antifibrinolytic agents and to consider only use of factor 7A in life threatening situations. And with this is my last slide. I think very important when you are doing certainly a major procedure on a patient on ECMO is not something benign. It should not be something like how I showed the case where in the middle of the night you just decide to stop heparin and put chest tubes. That should not be how it is done. Unless it is an emergency where you are not able to flow and support your patient, it's always a good idea to have a multidisciplinary approach to talk about the procedure, to weigh the risk benefit of doing the procedure, whether it is going to be helpful for your patient, and then also certainly having an institutional protocol and guideline is going to be helpful. With that, I'm happy to take any questions. Sorry about all the technical difficulties.
Yes, we can have got a couple of questions.
Psychoaches, it was excellent to learn from you. Just to ask you for our practice, you talked so much about epsilon aminocaproic acid. We on ECMO, maybe we're lucky, we've shifted to tranexamic acid. And following Gabriella's trial of the use of nebulized tranexamic acid, most of our patients, they are children like yours, undergoing an integrated ECMO for complex congenital surgeries like Alcapa, etc. We were seeing a lot of pulmonary hemorrhages despite up to 60-80 milligram per kg per hour antifibrinolytic with ECA. Now, that stopped immediately when we started to use 25 milligram per kg per body weight of tranexamic acid. Baseline, Rotum done, ACT done, then post-op, post-protamine, put on ECMO for 6-7 hours, a low-dose protamine neutralizing the heparin, and then giving high-dose antifibrinolytics in a nebulized way with tranexamic acid. Do you do it? Because we're using a lot of inhaled milrinone, inhaled epoprostenol, so this also seems feasible, but it's scary doing it. Are there some protocols?
I don't have experience using it on ECMO, but we do use inhaled TXA for pulmonary hemorrhage in non-ECMO patients, and I will say it has been pretty helpful. But we don't have an institutional protocol for using TXA on ECMO, so that's why we have stuck to aminocaproic acid. But I think most of the literature, of course, at least in neonatal patients, is because there is not much neonatal literature on use of TXA. But TXA is 6 to 10 times more potent than Amicar in the inhibition of the plasminogen pathway. Matt, maybe I'll ask you that question. Do you have any experience of TXA on ECMO?
Yeah, so we have an inhaled protocol that we're happy to share with you that we use for pulmonary hemorrhage patients all the time, and it works really well. My one comment about the choice of both of these antifibrinolytics, they both work. It's all a matter of
No,
dose.
but tranexamic acid more in adults and older children.
So,
Neonates still maybe.
so my one concern with tranexamic acid in small babies is that it has a single-digit percentage of seizure as a side effect. Whenever we see a seizure in one of those kids, we always worry, oh, have they bled in their head?
ACH.
So I choose to use
ICA.
Amicar in those patients simply so that I don't have to worry about that. But both of them work and both of them work.
this beautiful article of inhaled tranexamic on ECMO in Annals of Blood in 2022 itself. So, thank you.